Welcome to this explainer. If you're a doctor, a nurse, a dietitian, or really anyone on the front lines of patient care, consider this your curbside consult on the dietary management of obesity. We're stepping completely away from the latest internet fads today, and we're grounding ourselves firmly in the clinical evidence. We're going to break down the actual science of energy balance, dissect some head-to-head dietary trials, and apply all of it to real-world clinical scenarios that you can take straight into your very next clinic session.
So, let's jump right in and challenge a pretty common clinical misconception. We've all been there, right? A patient walks into the exam room asking if they should cut out all their carbs or drop all their dietary fat because they're looking for that ultimate, scientifically superior macronutrient split. It's a debate that just totally dominates the headlines. But today, we're pivoting to what the actual clinical trials show us about long-term success. And honestly, the answer might completely change how you counsel your patients.
Here is our roadmap for today. We'll be covering setting goals, energy balance and assessment, comparing dietary strategies, patient-centered prescriptions, and finally, the long game.
All right, Section 1, setting goals and hitting that clinical target. Think about the last time you had a completely overwhelmed patient sitting across from you. We need to establish a baseline target that actually matters for their objective health. When someone feels paralyzed by the idea of having to lose 50 pounds, simply reframing the conversation around an initial target of just 5 to 7% of their body weight, it completely changes the psychological landscape of the visit. It's highly achievable, and yet it represents a massive turning point in human physiology.
Because it's not just a number on a scale. This modest little percentage actively transforms comorbidities. Just look at the landmark Diabetes Prevention Program data. A 7% weight loss reduced the rate of progression from impaired glucose tolerance to clinical diabetes by a staggering 58%. We also see really tangible improvements in dyslipidemia and hypertension. This isn't just about weight. It's about fundamentally altering the trajectory of chronic cardiovascular and metabolic disease.
Moving right along to Section 2, Energy Balance and Assessment, the clinical workup.
Because at the end of the day, the underlying physics always comes back to energy balance. Let's imagine a hypothetical 100-kilogram patient. We'll call him David. By estimating David's resting metabolic rate and engineering a reliable 500-calorie daily deficit, we set up the mathematical foundation for him to safely lose about half a kilogram, or 1 pound, per week. It provides a very predictable initial rate of weight loss that helps set realistic, grounded expectations for David right out of the gate.
But hold on. Before we start restricting David's calories, we absolutely have to do a baseline nutritional assessment. It's kind of a crazy paradox in modern medicine that patients with obesity are often concurrently malnourished when it comes to key micronutrients. In your intake, doing a quick 24-hour dietary recall is just invaluable. We need to actively assess risk factors for vitamin D, B12, and folate deficiencies, particularly if the patient is on metformin, has a history of bariatric surgery, or if they're starting highly effective anti-obesity medications like incretin mimetics, which drastically reduce their intake.
And please, whatever you do, don't overlook protein. In practice, we find it absolutely crucial to hit targets of 1 to 2 grams per kilogram of ideal body weight. Why? Well, because when patients lose fat, there's an obligate loss of muscle and bone density that comes with it. Without adequate protein, we risk exacerbating sarcopenia, which is a really dangerous complication, especially in our older adult populations.
Okay, Section 3, comparing dietary strategies based on the evidence. Let's separate the internet hype from medical reality.
This is where it gets really interesting. When you put these diets head-to-head in trials, notice how low-carbohydrate protocols absolutely win the short game. They show noticeably greater weight loss at the 6-month mark. But look what happens by month 12. The playing field completely levels out across low-carb, Mediterranean, and low-fat diets. We also see that intermittent fasting, whether that's alternate day or time-restricted, essentially just functions as a vehicle for calorie restriction. It yields very similar weight reduction to traditional daily deficit diets, rather than having some sort of independent metabolic magic.
So, what's the bottom line here? The critical takeaway from the source material is this. The best diet isn't some magic macronutrient ratio. The principal determinant of long-term weight loss is simply the patient's ability to sustain adherence to it. Whether it's Mediterranean, low-fat, or low-carb, the physiological success is directly tethered to behavioral consistency.
Which brings us to Section 4, patient-centered prescriptions and shared decision-making.
So when you're counseling someone like our patient David, you've got to evaluate their psychosocial and cultural phenotypes. Like, does he love data and thrive on counting macros? Or does he just need the simplicity of a set menu or portion-controlled meals? Does he prefer to just follow internet-based guidance on his own? Or does he really need the accountability of a support group?
We have to find a sustainable, individualized path that maintains the actual pleasure of eating. Because let's face it, if David hates the food, the intervention is inevitably going to fail.
And hey, here's a fantastic high-yield clinical pearl for you. Simply advising your patients to cut way back on ultra-processed foods works absolute wonders. In controlled trials where patients were offered the exact same number of calories and macronutrients, those on minimally processed diets naturally ate less and reported significantly fewer cravings. It's a really foundational intervention that cleans up the diet without requiring obsessive calorie counting.
Finally, let's talk about Section 5, the long game, and managing those inevitable physiological adaptations. Let's look at how this plays out over time. At month 1, patients are usually highly motivated, and weight loss directly reflects the energy deficit. It's great. But by month 3, the loss of lean mass begins to lower their resting metabolic rate. By 6 months, for a patient like David, a plateau is virtually guaranteed. It's not that he's cheating on his diet, it's simply that his smaller body now requires fewer calories to run. Ongoing weight loss at this stage mandates either further caloric restriction or stepping up physical activity.
I mean, it really feels like a biological conspiracy against weight maintenance, right? When a patient loses weight, their body essentially treats it like a starvation event. Hormones completely shift. Appetite stimulators like ghrelin spike, while appetite inhibitors like leptin and peptide YY drop. The patient is literally hormonally wired to be hungrier while simultaneously burning fewer calories. And these adaptations can persist for over a year.
And this right here, this is where you, as the clinician, are completely indispensable. Our job is to destigmatize this regain. We need to explain that it's an expected, deeply rooted physiological response, absolutely not a moral failure or some lack of willpower. We arm patients with strategies to fight back, like aggressively reinforcing exercise to mitigate that metabolic drop, utilizing behavioral therapy, and considering high-protein diets, which have been shown in some trials to really improve satiety and help prevent that weight from creeping back on.
It's a total paradigm shift, isn't it? Moving from just prescribing a rigid diet to actually facilitating lifelong behavioral change. So I want to leave you with this provocative thought to chew on before your next clinic session. Knowing that long-term adherence trumps the perfect macronutrient split, how will you empower your next patient's dietary journey? Thanks so much for joining this explainer. Keep up the incredible work out there and keep empowering your patients with evidence-based, compassionate care.